Good afternoon, everybody, and welcome to today's webinar series from the UCLA Center for Health Policy Research. My name is AJ Scheitler, and I will be introducing today's presenters. You may have heard the old adage, smile and the world smiles with you. Smile is contagious. You see someone without a smile, give them one of yours. Because we all know that a smile can brighten up a room. And that's even more true when it is a small child who is giggling uncontrollably and can't hide their big toothy grin. But did you know that less than half of the children in Los Angeles who are enrolled in Medi-Cal receive preventive dental health services? Lack of these important appointments can lead to other health problems for children, can have long-term implications on their oral health and other health issues. They can lead to children missing days at school and just the general pain of not having a happy, healthy smile. So today we are going to talk about a program to address this very important issue. But before we do, a few housekeeping issues. You can view any of our recorded seminars on our website at a later time at the address on your screen. If you would like a copy of today's slides, you can email Vinitila, and her email address is on the screen. And at the end of today's presentation, we will have a Q&A session, which today is going to be moderated by Gila Moore, the Associate Director of More LA Smiles. If you're online with us and you have a question, just please use the chat function and we will get to your question at the end of the presentation. After today, we are going to go on a short hiatus and the webinar series will return this fall. Please check our newsletter and our website for the next restart of the webinar series in the next few months. Now we would like to welcome Dr. Jim Crall, a certified pediatric dentist and the chair of the Division of Public Health and Community Dentistry here at UCLA. His distinguished career includes time as the director of the HRSA MCHA National Oral Health Policy Center and the project director of the AAPD Head Start Dental Home Initiative. He currently directs More LA Smiles, the UCLA Dental Transformation Initiative. Dr. Crall and his associates are here today to share news about this project, which has just launched, dedicated to improving oral health services for 500,000 LA County children with Medi-Cal, Denti-Cal coverage, bringing all of us more to smile about. Dr. Crall.
Thank you, AJ. Thank you, everyone here, and Tia especially, for helping set this up and the invitation to close out this this part of the series for the year. Anyway, go forward. So I'm going to basically tell you about the project that we call More LA Smiles, or the UCLA Dental Transformation Initiative. I'll give you an overview of the project itself, but I also want to give you some insights into the genesis of how we developed the design for this project, how we decided on the goals and the strategies for the project, what the components of the project actually include, and then the rationale for why we're taking this systems-based approach for dealing with the challenges that we face, not only here in Los Angeles County, but California and across the nation as it relates to children's oral health. And we'll leave some time at the end for some questions. So this Dental Transformation Initiative, what is it? It's actually a part of the California Medi-Cal 2020 1115 waiver. And so because of attention that's been directed over the last several years about the need to improve oral health care for children covered by Medicaid, the CHIP program, when we had a CHIP program, and all children throughout California, but primarily the kids enrolled in Medicaid. The powers that be at the California Department of Health Care Services decided to include in its Medi-Cal 2020 waiver a component to help improve dental services. And that's called the Dental Transformation Initiative. It's about a $750 million commitment between now and December 31st, 2020. And good news, I was just over the last couple of days up at a California Oral Health Summit in Sacramento, and at least with the direction of the current administration, which we know will be changing come November and beyond, this is basically being viewed as the first phase of improving oral health care for young children. And so hopefully there will be subsequent work to build on what we developed through this dental transformation initiative. It really consists of four domains. The first, a statewide effort to improve the numbers of children actually receiving preventive dental services, because we know that kids who are covered by Medicaid are at higher risk and tend to have more severe dental disease, so the major emphasis on prevention. The second domain, domain two, focuses on new ways to use what we call Caries risk assessment, so risk-based prevention and disease management. Domain three, an emphasis on continuity of care, or getting children to come to the same place that we call a dental home on a repeated basis, rather than just seeking care when they have problems with their teeth. We want more of a health-oriented or preventive-oriented orientation. And then domain four, the local dental pilot projects or programs, and that's what we're really involved in, and that's what our UCLA Dental Transformation Initiative is a component of. As I mentioned, domain one is a statewide reach. Domain 2 and 3 are being done in selected counties and not in Los Angeles. But the thrust of this, to increase access, increase preventive services, increase the use of risk-based approaches, and to improve continuity of care, that really is the goal that guides all of this work. If you're interested in more, there's some links here to websites that the Department of Healthcare Services has put up describing the project and reports on the initial work that's been done to date. And in particular, there's a domain 4 webpage, and that's where the local dental pilot programs or projects are highlighted. So our project, and I'll get into more detail later on, but this is a statement we put together for the launch that AJ mentioned that we recently held here in downtown Los Angeles with many of our consortium partners and some local officials. And our approach really is to create this system change project. The local dental pilot projects, of which 14 have been funded throughout the state of California. Many of them are operating in much less populated areas, more remote areas, so they tend to be smaller in scale. Ours is by far the largest of the Dental Transformation Initiative local pilot projects. And again, we saw this as an opportunity to build on the work that we have been doing that I'm going to describe to you, and to really take this to scale and try to make sure that at the end of December 31st in the year 2020, there's a much better system in place here in Los Angeles to help serve the needs of children covered by Medi-Cal and Denti-Cal. To do that, we recognized that we need partners in this. And in fact, the way that the local dental pilot projects are structured, we at UCLA are serving as the lead, but we're the lead of a consortium. And that consortium involves many players here that I'll touch on later in the presentation. But we recognize that we need partners and we need substantial partners in order to be able to meet the needs of the large numbers of children that need services here in Los Angeles County. So, how did we design? What led us to design the program the way we have? It really stems back to the status of children's oral health in California and here in Los Angeles, an appreciation that tooth decay, what we call dental caries, is a complex chronic disease that has multiple social and behavioral determinants, and so the need for a more comprehensive, systematic approach, recognition of substantial barriers that exist, not just here in Los Angeles County, but they're very typical of barriers that have really presented challenges for improving children's oral health over time, and our experience working with some LA partners. So, in the dental world, it's very common to hear this notion that dental caries or tooth decay remains the most common chronic disease of childhood. That really started to gather some attention and some traction back in the year 2000 when there was a U.S. Surgeon General's report on oral health that talked about dental problems being the silent epidemic. It's not something you hear a lot about on the evening news or featured in a lot of news media publications, but it is pervasive and it impacts a lot of kids. 54% of kids in California have caries experience by the time they reach kindergarten. That's not 54% of the low-income kids covered by Medi-Cal. That's 54% of all California kids. And so we know that kids who come from low-income families and certain racial and ethnic groups, particularly Latinos, African Americans, Native Americans, have 3 to 5 times as much tooth decay, and it's more common than more affluent children. So California, from an epidemiology standpoint, we're a bit behind the curve in addressing oral health care for young children. And because caries is a chronic and progressive disease, by 3rd grade, that figure goes up to 71% of kids who have had caries experience. And a substantial amount of that tooth decay remains untreated, particularly in the lower income groups that are covered by Denti-Cal. The science base is telling us increasingly that early interventions are an important part of the overall strategy. We can't wait until children develop the disease and then try to, we have to deal with it. It's just not the optimal way to do it. The optimal way to do it is to get to these kids earlier, to get to the parents, even pregnant women, and help create an environment whereby that child's going to start out healthy and stay healthy and experience relatively little in terms of dental disease, as opposed to waiting until they already develop all the constellation of things that creates the disease and then try to unwind those issues. So, but this is a slide from a presentation I did at a symposium a couple of years ago, focused on what we call early childhood caries. So early childhood caries, by definition, is tooth decay in kids younger than 6 years of age, right? And the kind of the theme of the conference was the question that they posed to many of the presenters. Well, if tooth decay is such a preventable disease, why is it that early childhood caries is still such a problem? And my answer to that was that it's because we start too late. We have worked in relative isolation. I mean, this has been something that has generally been thought of as something that the dental profession deals with, and pretty much solely that the dental profession deals with. We have focused on patients, so people who make their way through and into the care delivery system. But as we know in Medicaid, the majority of kids, as AJ said, don't even get in for services. And so we need to take a broader approach that relies on population health and getting upstream in the determinants of the disease and get our preventive efforts out ahead of when people come in for clinical services. And to a great degree, I think we're still anchored, certainly within the dental profession and in the general thinking at large, in an outdated concept about what actually causes this disease, the determinants of this disease, and therefore ways to prevent and control it. So more on that to come. And the last thing is change is hard. Changing systems, as we've seen, whether it's through the Affordable Care Act or other initiatives that have been put in place over time, they take time to get system change in place. And it takes time to change the knowledge and attitudes of the public. about tooth decay as well. As pediatric dentists, which I'm trained as a clinically as a pediatric dentist, I mean, all too often we hear the old notion, they're just baby teeth, they're going to fall out anyway, why does it matter? Particularly, why does it matter when you're in a household facing a lot of challenges and have other things to concern about? So, unfortunately, I think a lot of the work that has been done of late, or attention, is on a fairly small scale. It's not really system change type approaches. And, you know, there's a lot of things that are kind of touted out from time to time that people think are going to solve this problem. Fluoride varnish is going to solve this problem. Silver diamine fluoride is going to solve this problem. Well, those simple notions about simple solutions, generally because of the nature of this disease, are not likely to be successful. And this is a quote from an article written by somebody I met years ago, Ulla Fireskov. He's from Denmark, reflecting on sort of how we've approached this disease over the years, and really have pointed out that it is a complex chronic disease. Complex meaning there are a lot of factors that can create the disease. So it's not a matter of just finding the one thing. You know, when I was a dental student, people were talking about the Caries vaccine that was going to happen, and it was just around the corner, and you'd be able to immunize kids and they wouldn't have tooth decay anymore. NIH gave up on that strategy years ago, so it's not the way we're going to deal with caries, right? We have made vast improvements here in this country and in most developed countries over the past several decades in improving children's oral health, but now we have still large proportions of the kids who really haven't benefited from that improvement, and we've got to take more comprehensive strategies. So this little set of figures that you see here basically show you from when this starts. This is how tooth decay starts. At least a clinician would just see a little white spot on that tooth. If you were a scientist and could section that and look at it under a microscope with polarizing light, you see this area where the minerals going out of the tooth. You know, it doesn't just break down, but eventually it'll turn into what we call cavities. And if those aren't addressed early on in young children, they spread very rapidly. And they actually, those darker areas you see there, that's part of the tooth where there's actually blood flow. So that is part of the circulatory system. That same blood goes past that tooth, gets infected, runs through the heart, runs through every other part of the body, and unfortunately, occasionally creates some very serious problems. That's a picture of Diamante Driver, a 12-year-old in Maryland who died in 2007 because he had an infected tooth that his mother, who was covered by Medicaid, couldn't find help in getting treatment for that tooth. He made it to an emergency room. He made it back to a hospital for brain surgery because the infection spread from his tooth to his brain, and he died for something that could have been handled with an $80 tooth extraction. Not optimal, but an $80 tooth extraction. So that's the subsequence, and there's a whole range in between that of kids missing school. It's one of the most common reasons kids miss school for dental problems, and so that's what we're up against. So we've been very fortunate in the last 5 years to be working on a couple of projects that were funded by a local organization called First 5 LA. And we were charged initially with working with up to 12 federally qualified health centers to improve their capacity to serve as dental homes for young children and pregnant women. Our second part of the work builds on that, and we took the same strategy. We also were charged with identifying what the barriers were. Why weren't kids getting the kind of care that they needed when they came to these primary care community health centers, right? And we found in those first 12 clinics that there were 10,000 preschoolers being seen in those 12 clinics for primary care medical services, getting no dental services. Right? So these are the barriers. There are gaps in the knowledge and skill set of dental providers. There's gaps in the knowledge and skill set of primary care providers, which are increasingly being engaged to help with this because we know kids see primary care providers multiple times before their third birthday, and we want to try to take advantage of that opportunity. There's gaps in infrastructure, both in terms of the kind of personnel that work in these settings. There were no pediatric dentists working in these settings. There were general dentists, but no pediatric dentists. And the general dentists there weren't all that comfortable working with young children. There are IT gaps. You have electronic health records and you have electronic dental records, but they tend not to be interoperable and connect to each other, right? So you can't flag kids on the medical side who need a dental exam or a fluoride varnish and vice versa. So all of those kind of things. Leadership is an issue, right? Until the leadership of those centers are convinced that oral health is important, leadership meaning the people that look at the finances as well as people who lead the dental service and the medical service. It's not going to happen. Things are not going to change. And then most of the focus, even in these clinics, was still on people who come into the clinic instead of an outreach sort of an effort to link to community programs. So we took what we knew from all that, and we put together what I think is a fairly comprehensive approach to doing this. We recognized that we had to work inside the center to improve the systems of care and redesign the care pathways, and we needed to help those programs connect to their communities and to get the people upstream in the process. And so we engaged partners like Sesame Street and the Child Care Alliance of Los Angeles, Head Start programs, etc. But we also engaged some experts on helping that knew about how to change clinical operations within the clinics as well. That's the list of the 22 clinics we worked with, 20 of which were what we call co-located, meaning they had a primary care medical clinic and a primary care dental clinic under the same roof. That's not all that common in California or in the United States of America. Most of those FQHCs don't have a dental clinic. You can see they were scattered around Los Angeles County. But the other thing that was staggering and made us think when the dental transformation initiative came along, we have to do this at a bigger scale, is the observation that there's over 500,000 preschoolers in Los Angeles County covered by Denti-Cal not getting services. So, I mean, we have basically the population of the state of Michigan right here in Los Angeles County, and those kids are not being well served. So this is the strategy. We are looking to use more of a population health approach to get upstream in the process and also develop efficient channels to use the clinical resources as efficiently as possible, working with community partners. The funding for First 5 LA was generous enough that it allowed us to take a multifaceted approach to help build the infrastructure within those clinics, to help provide training for various types of clinicians, to conduct quality improvement methods, to apply quality improvement methods. We use the IHI Breakthrough Series and several cohorts of that to redesign care processes and what we call community systems development, building those linkages and getting outside the process. That led to us developing what we call our integrated risk-based care pathway, which was designed specifically to reflect care provided in these FQHCs. But essentially, I look at those FQHCs, those co-located ones, as a microcosm of the entire system. So I think this approach is applicable on a much broader scale. You just have to start thinking about other entities to get involved in the care coordination process and some tools to help facilitate the movement of kids if they start out on the medical side to the dental side, and some monitoring over time. And that's what we're looking to do in the DTI work. We had folks here, Nadi Parat and Anna and other colleagues here at Zhao at the UCLA Center for Health Policy Research involved in the evaluation of that First 5 LA work, and we demonstrated that we could significantly increase the number of kids getting seen, young kids and getting seen, and then preventive services provided to the young kids. You can see that graph going up. We did some policy-related work looking throughout the state of California and by regions within California about just what was the infrastructure that was there in the federally qualified healthcare system, the community healthcare system. And we found that basically only 1 in 3 FQHC sites in California, like the US, have a dental clinic. And in LA County, it's only 1 in 4. Only 1 in 4. So how do we get care to all those other kids? Right? We were successful, in hitting the targets. Between the two first 5 LA projects, we had a target of 43,500 kids that they said they wanted to help us improve. Last analysis of the data, we had over 75,000 kids served. So we definitely showed that there's a willingness and there's ways to increase that capacity even in existing sites, while we continue to work on the policy side to emphasize that we need more of these dental clinics in the FQHC sites. And this is a story of the March 10th, I think, LA Times that features a great story about how a mom shows up in a clinic with 3 kids in the primary medical care clinic at up in the Antelope Valley. She gets her services, but the folks there who were participating in her project actually brought to her attention that these kids were in need of dental services. And they did what we call a warm handoff. They actually just took them right over to the dental clinic on that day, and they were seen. And this story tells about how the mom, all she could think of when they told her in the medical clinic that her kids need dental care is, how am I going to get all this kind of organized again and get back here for another time or whatever. And the fact that she got it all done on the same day, really, the data are important, but those kinds of things really tell us that the work that you're doing actually makes a difference on a day-to-day basis. Okay, let's shift to DTI. So DTI, our first 5 LA work just concluded at the end of February this year. DTI came along as an opportunity late in 2016, and by the time we get our proposal in, a DHCS reviews it and we get approved, it's 2017. But we really saw this as an opportunity to take what we'd learned in the first 5 LA work and sort of take it to scale, right? So we were pretty bold in terms of what we put into our proposal and our application. But that was really, built on the fact that about 1/4 of all the kids covered by Medi-Cal or Denti-Cal in California live in this county. We're one county, but 1/4 of those kids are here. So the numbers, really call for doing something on a larger scale. And fortunately, the folks at DHCS recognize that, and we're grateful for their funding. We did really structure this thing around systems transformation, and the little sort of phrase we use to describe going from the first 5 LA work to this work is going from retail to wholesale. We thought we had our hands full working with 22 clinics. We're really looking to work with a much larger group of folks over that. So we set out a bold target of 500,000 kids to improve care for 500,000 kids covered by Denti-Cal. And remember, this is not just about the young kids. This is about all the kids covered by Medi-Cal or Denti-Cal, which basically is from birth up to age 20, not just age 5. So that was part of the reason why we felt we could take on a much larger number than the 75,000 we served through first 5 LA. And the other is we have a partner working in this that I'll talk about in a little bit, and they had experience in the state of Michigan serving large numbers of kids through these strategies. And so we felt that was a credible projection about what we could do. The emphasis is on redesigning delivery systems and provider incentives. If you're going to change behavior, you have to do something differently, right? You can't just keep doing the same thing and expecting a different result. And so a lot of that involves developing new linkages for early intervention. Some of that linkages are on the ground across providers and among providers in community programs, but some of it's at a much higher level as well, working with plans, the Medi-Cal plans and the Denti-Cal plans that operate here in LA County. And clearly there's a communications piece that's really important. You can't just work with the providers, right? The parents and the caregivers of those kids have to understand the importance of oral health, and that this really doesn't have to be, you don't have to be fatalistic about this. These kids do not have to develop that extensive dental disease, but in order to change that, we've got to educate the public and to help connect them to the services that we are recommending that they receive. So we build on the work that we've done, the policy work here with the folks at the Center for Health Policy Research, and we knew that we couldn't just focus on federally qualified health centers. They're an important component of the care delivery system for disadvantaged people, but they're a small portion of the delivery system. And we had to find some way to deal with those sites that don't even have any capacity to deliver dental care. So as I mentioned earlier, we're working with this consortium, more on that later. Our consortium partners include the two major Medi-Cal plans, LA Care and HealthNet, that operate here and provide benefits in LA County, along with some of the other plans that they subcontract with, as well as the dental plan. So LA is one of only 2 counties in California that have dental managed care for Medicaid. The other is Sacramento, where it's mandatory, so it's all done through dental managed care in Sacramento. But in LA, it's called voluntary. About 85% of the kids still get their Medicaid dental services through the Denti-Cal fee-for-service system. The other 15% get it through 3 dental managed care plans, and we're working with all of those plans. We're also working with dental provider organizations and medical provider organizations, because the plans have one kind of a relationship with the providers down there at the street level, but their membership organizations have a different relationship. So, people who are a part of either a dental society or the local chapter 2 of the American Academy of Pediatrics, they have a different relationship with their professional organizations, and they look to them for different types of things. So we're working with both the plans and with the provider organizations. Also community-based organizations, the Community Clinic Association in LA County, WIC programs, Head Start programs, home visitation programs. We're looking to work with all of those. And then county agencies. The LA County Department of Public Health now has a much more robust program thanks to Prop 56 funding that's actually providing funding coming down for more public health kinds of things. So for our consortium partners, they can help us in multiple ways. They can help us promote these training programs we have in this that I'll tell you about in a second. They can also help us with some of the infrastructure work that we're trying to do to change that system. So the strategies and the key components we have here, one is we know, again, we do need to continue to train both medical and dental providers into the nature of this disease and contemporary ways of helping families and kids avoid the consequences or minimize the consequences of this disease. So we have a target of 1,500 medical providers and 1,600 dental providers that we're looking to provide various types of training for. Quality improvement, we're actually operating at 2 levels here. We have a quality improvement component that is geared exclusively for primary care medical practices to help them implement oral health services within their own practices. And we have an extension of our previous IHI type work, breakthrough series approach, where we're bringing together multidisciplinary teams and clinic administrators together, practice administrators for that part as well. So medical players, dental players, and people who are responsible for the business in those things. Strengthening community linkages, increasing the outreach and coordination. So a lot of this involves providing trainings for groups like Head Start and WIC, but we're also looking to see if we can work with them to help them facilitate referrals and connections of kids who are identified who actually need services. All the kids need some kind of services, but a lot more of those kids actually get seen or participate in these community programs than are currently making it through at least the dental part of the delivery system. So we're working to build those connections as well. There are aspects of this project that focus on technology. One we call Ladder, or a Los Angeles Dental Registry, and that is really meant to use cloud-based technology, information technology, to allow primary care providers to capture, record information on children covered by Medicaid, Medi-Cal, and then to generate referrals to the dental provider network. Not just give mom a list of here's 5 dentists and call these dentists and see if you can get an appointment, but it actually generates an electronic referral. And there's another piece of software called Smile Connect Community, which really is about helping local programs who probably have much smaller numbers of kids that they're looking after, but if they can register a need. I need some help with somebody doing education for my parents and kids. I need somebody doing oral health assessments, screenings. I need somebody to help come and do some preventive services for me right on site, or referrals. And they can register those needs, and then the program also works to build a pool of providers who locally can then say, oh, there's a Head Start program in my neighborhood. I'll help with that program, right? So that's another piece of technology. We call it Ladder, and you know, I described the functionality sooner. It's actually, we're working with a group called Altarum from Michigan. They were funded by the CMS Innovation Center for a period of a little over 3 years to put in place several of the components that we are looking to put in place in Los Angeles. So rather than starting from scratch and having to build these programs, particularly information technology types of programs like Ladder, we're working with them. So in Michigan, they called it MITRE, for Michigan Dental Registry, but that has been put in place on a statewide basis in Michigan now, and has been incorporated into the funding for the Medicaid program going forward. So the CMS funding is over, but the program has been institutionalized within the state of Michigan as a resource. We have several contractors, and I've listed here the things that Altarum is helping us with. We're also working with colleagues at UCLA and RAND and DataStat to update a dental CAPS survey. There isn't a pediatric dental CAPS survey that's an accepted part of the ARC suite of CAPS instruments. So we're looking to update one that we previously used with the CHIP program in California with Mr. Mib, and to bring that up to current standards, and then use that as a read about how consumers, the parents, actually view the care they're provided, as well as their interactions with the plans, medical or dental plans. And we're working with colleagues at Western University on the training component as well. It's nice to have somebody on the other side of the county who has relationships there just because of travel times and practicality. All our work is really guided by that notion that caries is a chronic disease and that we need chronic disease-based approaches to doing this system. So recognizing that health services are important, but the way the health system has functioned in the past needs some additional support, whether that be in the form of infrastructure like IT, decision support for clinicians, things like caries risk assessment and tools and how to use that. But the health system can only do so much. And to really be effective in chronic diseases, that health system has to be connected to a set of community partners who can help to create what the lower tier shows, an activated patient who actually knows something about the kinds of services and what can be helpful in the disease process to make that a much more effective interaction between clinicians and patients. The big value of this, it's multifaceted. If you care about cost, which people running programs or clinics for that matter, or practices have to be care about cost, this is some work done in the state of North Carolina with federal funding that clearly demonstrated that if you look at the health-related cost that are related to kids' dental problems. Not just whether the cost of their fillings and their fluorides and their exams, but if you look at fold in the cost of when those kids show up in an emergency department and what that hits the medical side with. You look at the cost of the kids that have to be treated under general anesthesia in hospital settings or surgery center kinds of settings. If you can, the earlier you can get to those kids, the lower it will be their overall cost over the entire preschool years. On the other side, the human side, basically this work shows that there's going to be much more positive experiences for everybody involved if we start early, right? These kids mostly get checkups and preventive services and some fluoride. They don't have to have teeth drilled on. They don't have to have those 4 front teeth taken out the first time they show up. So that's easier on kids. That's easier on parents. That's easier on dentists. And so it makes a much more positive experience. So with that, that's an overview of our first 5 LA work, as well as our UCLA Dental Transformation Initiative, or more LA Smiles, as we refer to it. And I'll be happy to take any questions.
Do we have any questions from the audience? Yes. Do we have any questions?
So is there any shortage of dentists serving Medicaid kids?
Yes, and I'm glad you added, it's a separate question, right? Is there a shortage of dentists serving Medicaid kids, or is there a shortage of dentists, right? You hear both of those questions. I'm pretty confident in saying that overall, there is no shortage of dentists in Los Angeles County. Los Angeles, like a lot of other big metropolitan areas, serves as a magnet for dentists. We have 3 dental schools, 4 if you include Loma Linda, right here, very close proximity. I can tell you from UCLA experience, and I'm sure it's true for most of the others, those graduates tend to sort of stay around the area. Maybe not Los Angeles County, maybe they're in Orange County or whatever. But when you look at the percentage of those dentists who actually are signed up and participate in any meaningful way in the Medicaid program, it's a low percentage in California, right? Now, other states have taken steps to increase that percentage, and clearly that is one of the goals of the big Dental Transformation Initiative, the DHCS, Dental Transformation Initiative. The way that's being addressed is in part through the DTI project, which has an emphasis on the prevention, expanding access, but mainly on prevention. And then Prop 56, which is a relatively new tobacco tax that the voters of California have approved back in 2016, that has now started to generate revenue. There's a part of that funding stream that's also being dedicated to improving the payments to Medi-Cal providers and Denti-Cal providers, because funding is not the only issue in reimbursement, but it's a significant issue in California. We have lagged in that regard. And again, we heard from DHCS officials yesterday, they have no notion that they're ever going to match even commercial payment rates here in California, but they're looking for some creative ways to try to make it a better proposition.
Thank you. And just wanted to also note, if there's anybody that's logged online, you're also welcome to submit your questions via the chat box, and we will present those as well. Do we have any other questions from the audience here? Yes?
Hi, that was a really cool presentation. I'm wondering, has there been any headway? Has any headway been made on exploring either like making it easier for parents to do both like medical visits and dental visits? So you talked about that warm handoff. Has there been any like reimbursement platform made to incentivize dentists in hospitals or dentists like homes around hospitals?
Yeah. To some degree, that domain one of the Dental Transformation Initiative, some of that funding actually goes to the dentists working in health centers as well as in the private sector as well. So there is some effort to try to channel some funding there. It's more than just the funding, though. I mean, what we found working with those clinics is that I mentioned the 10,000 kids who were getting primary medical care services weren't getting dental services. The medical people didn't even know the dental people. I mean, they just don't routinely interact. And so it's only when you bring them together to work collectively to solve a problem does it happen. The financing is clearly important, and funding is important for sustainability and for convincing someone to leave the comfortable mode, whatever their practice currently is operating in, and to do something differently. I think the funding certainly can help in that regard. But oftentimes it's just that there's an isolation that doesn't even have, I don't think it's even intentional. It's just historically and culturally the way that we've let dentistry sort of exist in a separate sort of silo or tunnel over here. And medical hasn't been engaged, in the community folks not so much. That was always sort of public health. So it's really, finding new ways to connect the medical providers, the dental providers, and the community-based programs, or anybody that's really caring for kids in a way that make it much more effective, and to get the message out. That's why I use a little buddy Ernie here. We've had some opportunities over the years to work with the folks at Sesame Street. And oh, by the way, I just found out in the summit yesterday, I mean, there's going to be a whole new campaign rolling out in September, statewide campaign, to try to create much more awareness about this importance of oral health and what needs to be done. Because as a chronic disease, estimates are that 75 or 80% of the determinant of whether a kid's going to have that disease and how significant it's going to be are related to sort of home-based behaviors, right? I mean, finding ways to get parents and caregivers to start brushing kids' teeth with fluoride toothpaste at an early age, whenever those first teeth start to erupt, and to be sensitive about sugar ingestion. I mean, there was a recent article out in the last week or so that the infants in the United States ingest more sugar than the adult recommendations, the adult limit, right? And that's an infant. So, there's a lot of facets of this that really do need to be addressed. But I mean, working together, I think that's the main message, is that we need much more collaborative approaches. That is what we have learned through our work, that, you're not going to solve this with simple kinds of things, sending people out and painting off fluoride varnish, things of that nature. It's got to be some of that.
Thank you.
But it's got to be more.
Another question is, Dr. Crall, you mentioned about the Oral Health Improvement Collaborative. Could you give a little bit more information on that in terms of who's eligible, what's the commitment, what's the time frame?
Sure. So in our first 5 LA work, we called that the Quality Improvement Learning Collaborative. In the new project, we're calling it Oral Health Improvement Collaborative. The first wave, we're looking for 10 to 12 clinics primarily, although they are open to looking at some large private provider groups as well. And we're looking for representation of medical providers, dental providers, and a mix perhaps with some community programs as well, to figure out, again, we're trying to move beyond the co-located FQHC model, where we know that that's only 1 in 4 clinic sites in LA County, FQHCs, that have a dental clinic. So what about the kids that go to those other 3 clinics, right? How can we help those clinics get those kids channeled in to oral health care in what we call a dental home, right? Maybe referring to another clinic that organization has is a reasonable strategy, but maybe that's the transportation challenges are just too much, right? But there may be many private sector dentists in the area that if we had a tool like Ladder, we could actually start to just facilitate those referrals and monitor the what happens after the referral happens. So I think that's what we're looking to do with the first phase, right? Eventually, we'd like to grow that. But the Oral Health Improvement Collaborative, the IHI model, is a more intensive time commitment. You basically have to come and participate in 3 learning sessions, and then there's work that happens, a little bit of pre-work, and there's work and coaching that happens after each learning session. But that's the IHI Breakthrough Series model. The other approach, the primary care practice-based quality improvement, all basically happens within the context
Thank
of
you.
that
And
practice.
just want to note that for sites that are interested in participating in the Oral Health Improvement Collaborative, applications are currently being accepted right now for a September start date. So if you are interested to sign up, you can email our general inbox of morellasmiles at ucla.edu, and someone will be able to follow up with you and provide you more information on that. Do we have other questions from the audience? Yes.
Hi, Tim. Yeah. It's a very nice introduction of the project. You mentioned 1 out of 4 of the FQHCs, they have dental component. It's clearly, I assume, for the 3/4 of those who do not have dental component, those patients actually use that facility. I assume their prevalence, say for kindergarten, you mentioned like about 50%, right? In general, 70% 3rd grade. Do we have hard statistics available for those FQHCs? They do not have a dental component about their for the needs of the health status.
The needs for the kids, their oral health status. Well, at least the kids, those that now make it to the dental service, the dental clinic within those places, right?
Yes.
That information would be recorded in the electronic records system over there. LA county-wide, we don't really have that. There was a study done with First 5 LA funding several years ago in some Head Start sites in some places that were serving young children. But in terms of a representative sample of the population, we don't have. As you know, part of that new Prop 56 funding, some of it, as I mentioned, is being used to enhance Medi-Cal provider and Denti-Cal provider reimbursement. But there are other aspects that are flowing into the local health districts. And there is a statewide needs assessment that's being done of kindergartners and 3rd graders here in LA, and will be done kindergartners and 3rd graders throughout the state over time. And so we're happy to be participating and partnering with Los Angeles County Department of Public Health in that effort here in Los Angeles County as well. But we need better statistical data to see that data I showed you on the 54%. That's the 2006 California Oral Health Needs Assessment. That data is quite dated.
It seems like that's a big potential for PROMIS 2 can be used to evaluate, right, the statistics for the 3/4 of FQHC. Of course, you mentioned that's only part of the whole spectrum, but I think, like, for example, PROMIS 2 can be used in that settings. You can get initial statistics that will be hard statistics, that eventually can convince to actually establish this dental component. Second is can actually later evaluate the effectiveness of before and after.
The effectiveness of
Yes.
Yeah, and for those that don't know, PROMIS is a part of the NIH roadmap on patient-reported outcomes. It's using patient-reported outcomes. And so there clearly is an interest at the state level about having a more dynamic surveillance system in place, and that's what part of the Prop 56 money will be used for. We can't wait 10 or 12 years between gathering data to know whether the problem's getting better or getting worse. So there's definitely an emphasis on that as part of the new state oral health plan that's been approved now.
Thank you.
Released.
One question that came up in the chat box is there any plan to bring dental mobile to schools or kindergarten to provide oral screening or oral education? And will there be reimbursement for this kind of service?
Well, there currently are some, in the dental world, we tend to make a distinction between what we call a mobile program and a portable program. Mobile in dentistry generally refers to a van that's set up with dental chairs, much like you see some of the vans that go around and do vision services or whatever. But a mobile dental program actually takes the van and all the equipment and everything to the schools. The portable approach basically uses equipment that, with current technology, can actually be fairly compact. And you can literally just put that in a vehicle and take it out to the school and set it up in a spare classroom or some kind of, excuse me, some type of a facility right on site at the school. So that's going on to a limited degree within some of the LA County schools. There are other programs that Healthy Start. There are some personnel and there are nurses that function within the school settings. And so there's a variety of resources that are used there. But first of all, I'm not aware of any program that currently that is actually looking to, sort of blanket the county to do that in a universal sort of sense. It's sort of a little bit more here and there. Whether or not that could happen, the Prop 56 funding, LA is going to get just a little under $3 million per year as that the LA County Department of Public Health and the Oral Health Program. They are beginning this fall to develop a strategic plan about how to use those sources. What might evolve from that, I can't say. We look forward to participating with them in the development of that plan. And but I think there's a definite awareness and interest in making what's called the kindergarten needs assessment, the kindergarten assessment, which is a law, AB 1433, that was passed a few years ago, but it hasn't been implemented to a high degree. The LAUSD Board of Supervisors actually have passed a resolution to really try to be more helpful and to emphasize this with superintendents and teachers, and that this needs to be done. But I can tell you, up to now, the proportion of the kids that they're actually we're actually gathering data from that assessment is too small. It needs to be.
Do we have any last questions from anyone before we close? Okay, thank you. Thank you so much for participating. Thank you, Dr. Crall. And for more information regarding the More LA Smiles program, you could visit our website at morelasmiles.org. Thank you.